Just I have a number of questions in relation to obviously the medical or the report itself, because obviously that's why we're here and so forth. Would you agree that the lack of clinical oversight and governance was at the heart of the report, the injury report by the Medical Health or the Mental Health Commission? Would you agree with that kind of assessment?
I think it's one of the recommendations that's there that's very strong in terms of the model, but I think there's a broad range of areas within it that we will need to tackle and address. So I wouldn't say that it's the sole issue that's there or there's the only issue. I think there's a broad range of issues identified within the report to improve the service, and the report also recognises in some parts of the country and in some services it's working really well. We talked at the start about the number of young children availing of the service, but just team may want to comment on that. I mean, I think there's a broader range. I don't think to isolate it, I suppose, would be my response. I think there's a wider range of things that we need to tackle, and that's why that National Improvement Programme, building and pulling all the threads of the reviews together, is just so important to get as much cohesion and consistency as we can in terms of the service throughout the country. Because, and I'll be frank, in any one of our services throughout the country, if you have 73 teams, it's inevitable you get some variation. So the challenge for us in the system is to try and make it as consistent for people as possible, accepting maybe that the service in urban areas, rural areas, there's a range of factors that impact on that. But others might want to comment.
Well, I suppose, look, from running a service that crosses both urban and rural areas, I can say that, when you do have staffing deficits, right, if you don't have another area that you can draw on, right, to cover that area, but then you have a challenge, right, because you just can't make two of yourself, right? Whereas if you have a number and a core clinical staffing that you can spread around the place, it's much safer. So from a governance point of view, I do think we're going to have to tackle the kind of model of care piece, and it's not a popular one to tackle, because what it means is you cannot provide the same service in every geographical area, right? And we know before that has caused problems, because people feel that they're not getting a good quality service if they don't have a CAMHS team on their doorstep. And this is a personal view. Personally, I think if you cannot fill and properly staff a team over a number of years, well, then you need to look at your model and you need to change your model of care. And the evidence base, and we need to look at evidence base and be evidence informed. The evidence base for therapy is for people who do a lot of the therapy and see conditions a lot, right? Not for somebody who's only seeing one or two a year. So what we need to do is we need to get a cohort of people. I believe in a hub, right, that can in-reach then, and I'm not suggesting that we need young children to be travelling long distances. We can get our staff to travel, but we can use a hybrid model, and we can go down, we can do clinics and things, but then we can have centres of excellence for particular, maybe more rarely occurring illnesses. For example, we need a good solid programme for early intervention in psychosis. It's rare, but it's really serious, and we need to get in there early, and we need to have a really solid evidence base to it. The same with eating disorders. So I favour a programmatic approach, and I think that really strengthens the governance. But I do think to do that, we're going to have to take a hard look at what the model that we're pursuing at the moment, which is trying to provide everything everywhere.
What would your opinion be on what would constitute a non-safe environment in relation to staffing levels?
I suppose if you don't have a strong clinical oversight, if you don't have somebody who's responsible for the coordination of a care plan, right? And I mean, we can have a discussion about who should lead the team, but at the moment that is vested in the consultant psychiatrist, right, who has responsibility for the care and treatment of that young person. They may not have to deliver that themselves, but they have responsibility for coordinating that. So there needs to be a consultant available at this moment in time to all young people attending camps.
That's not happening.
It's not available everywhere, right? But we are trying to be innovative, and I suppose that's what I was talking to. You can use your e-mental health to provide consultations. So you could have another health and social care professional with the young person, but you could have the consultant at the end of a video link, and then you could use the hybrid, so they could meet them face to face, develop a relationship with them, and then they could have review appointments appointments via e-mental health so that they weren't travelling long distances. We're going to have to look at that. It's commonplace in other jurisdictions, because this isn't a problem that's unique to Ireland.
Where the consultant is physically not in.
It's physically not in.
Okay.
Yeah. I suppose in Australia it'd be very common. They're way ahead of us in this, but also in large parts of America, it's really hard to source thing, and this is commonplace.
And in practice, what would that look like?
In practice, what it is that you would have like a core team on the ground, who would get to know the young person, who would conduct the assessment with either the consultant available by video link, or who would do the core assessment and then present it to the consultant afterwards.
Okay. Just in relation to the Commission's report, in relation to, I know that we're alluding back to the original kind of tenet of the Commission's report about underfunding and understaffing. It alludes to that, and obviously with a situation where there's understaffing, there's kind of governance issues and clinical oversight where it doesn't happen. What would your kind of commentary be on their kind of assessment that the cause of deeply, in their words, it was deeply underfunded and understaffed in relation to some of the situations that had arisen in relation to their assessment?
Just to come in on that first, Deputy, just on the underfunding, I mean, clearly we will need to continue to invest. The numbers I gave at the start in terms of the numbers, we need to continue to invest in youth mental health services. I know we've focused in on CAMS, but we talked at the start about the wider access to in primary care. Psychology is just as important, because then people don't get that access, then they will fall into CAMS. At the moment, one of our challenges is actually ensuring we get that recruitment retention strengthened so that we can actually fill posts we have. So there are certain areas where we have funding, that's not the barrier, but we will need clearly more funding over the years in order to fill out the teams, notwithstanding, I think, as Jim and Mandy and Amir have said, the need to look at the model now in the context of what we've learned. I suppose Vision for Change was written many, many years ago. It set out a model based on a population, 100,000, 2 teams and so on. And with the sort of scenarios that have been described, that just needs to be thought through. And it may be, as has been mentioned earlier, it isn't the same everywhere for the reasons that we've talked about here. So I think there will be more funding, more investment needed in a range of areas to strengthen up CAMS, but I think also we have a challenge to make sure that we can get actually more people through into the teams for posts that we're funded for that are vacant and that I mentioned at the moment. So I think it's more of a multi-year challenge in my view than an immediate challenge, in the sense we need to try and get that pipeline so that we have more people, and all of the other work around the IT system, around the models of care, around the hubs, and all of the more specialist areas that have been developed as well, and those will need funding. Now clearly if some of those get real traction, that may bring a funding requirement quicker, in terms of some of the things we've discussed here, such as the hubs, such as the specialist teams that Amir has mentioned as well.
It may be worth mentioning that over the last 5 years, it's 22 million additional funding have been allocated to CAMS in particular, and we've about 136 million is what we spend on CAMS, but that doesn't include money that's been spent through primary care on young people's mental health. So there are other areas of the HSE that spend money on youth mental health, which is not just CAMS. So it's important that sometimes the figure says we're only spending 12% on CAMS, but actually it's an addition onto that in relation to what's been spent in primary care and health and well-being and other parts of what's been spent on young people's mental health. Clearly we need to have the right staff in the place at the right time, and that's what we're trying to get to. But I think the point that Dr. Burke is making is that with Vision for Change, that was of a time. We know we do need to look at the model, because we're not going to be able to provide all those staff in all the places we need in the way in which Vision would have initially looked at. It's interesting, the sharing the vision, which is the updated version, I suppose, of Vision, didn't mention the actual numbers. It spoke about domains and about outcomes, and that's what we need to focus on really. What's the best that we can do for young people who need those services? CAMS at the end of the day is for 2% of the population, the youth population. That's the numbers that CAMS need to focus on, because what sometimes happens is that we end up with a lot more young people seeming to need CAMS when in fact they need a lower level of engagement earlier on in order to make sure that they don't move up through the system.
Okay.
Deputy, definitely we need more funding, but at the same time, like if you provide more funding to us today, we might not be able to spend it because we also need to have staff available, trained staff available to recruit and all of that. Like just to say that Vision for Change came in 2006, which recommended one consultant for 50,000, a team for 50,000. Since then, like things have progressed on internationally and even here. To give you an idea, the clinical program started in 2010, 2011. And just for the clinical programs, like the eating disorder specialist teams, in the last 3 years, we have developed 9 teams. And out of those 9, 5 teams are for children. So we need to have another 3 teams to have a full circle available in the country. MHID in children, we completed a model of care 2 years ago, and it was launched last year. And we have a funding available for 14 posts. For full program rollout, we need 18 posts, but we have 9 people at the moment. So 9 teams have been added on top of the 73 teams that we say. So 9 teams in MHID, 5 teams in eating disorder. And if I go on, say the other list, dual diagnosis, like we are hoping to launch that program this year. There is going to be 4 hubs for children, and the first hub will be in Dublin, CHO9, that we are hoping to start on. So that will be included. The CAMS ADHD, as I said, the model of care we are hoping to start now. That will include the continuity model with the adult ADHD. On the perinatal program, on the hub sites, there are consultants recruited on that program which will look after up to 1 year of age and provide support for those ones. Early intervention in psychosis for children, like over the years we will be rapidly developing those teams to provide support to children with early intervention psychosis. Self-harm, we already have self-harm nurses for children in the 3 hospitals in Dublin, and we'll be replicating with the scan nurses for those children. So, and then the CAMS liaison teams, that is a model of care which is very near completion, and a professor who is completing it. So what I'm saying is we have definitely increased the number of teams over the last few years from 60 to 73. But on top of it, these are the specialist teams that have been added on and which were all developed post Vision for Change. So these are the new developments that have happened since the vision came, which recommended. So if you add on all of those teams, we have a lot more resource available for children. And it, like all of these teams happen with the extra funding that was provided to support children, and we'll continue to replicate them. But we also want to keep a balance. We don't want to develop more of specialist teams and losing people from frontline secondary mental health services. So we want to keep the balance to develop those 73, to build on those ones to reach the 101 teams target, but at the same time continue to invest in the specialized teams and find the right balance between the two.
Thanks, and that's very welcome. Just my final question is in relation to over-prescribing, which is part of the report. And it points out that some children were on antipsychotic medicine for years without kind of, I suppose, oversight and clinical oversight. And one of the kind of the report kind of states is that there was a failure to provide alternative therapies in relation to over-prescribing, because it's deeply troubling that some children could be on medications such as antipsychotic medicine. And I'm not saying there's not a place for antipsychotic medicine in psychology, but the over-prescribing is deeply troubling, to say the least.
I'll start it, then I'll ask Dr. Berg, being the expert in CAMS, to say that. Deputy, we just completed the prescribing audit, right? We have around 21,000 children who are attending CAMS services. And out of those 21, around 8,000 are on medication. This audit, we saw about 3,500, so almost half of the children who are on medication. It was a random sample, completely anonymized, that we picked up. So which means it's a fair reflection of having a sample of almost 45 to 50% that we looked at. If you look at the findings of the audit, it says that almost 70% of those children were on one medication. 24% of those children were on two medication, 23% are on two medication, and then 4.6 were prescribed three medication, and then only 0.5% children were on medication more than that. If I compare it with any international audit or any other study, I think it will reflect that. I think Dr. Burke might be able to say what I have spoken with, that there are areas where we are under prescribing, but I do acknowledge there are cases where it has happened, and it is mostly when there is a multiple diagnosis, somebody with challenging behavior or autism or other factors play a part where overprescribing might happen, and also in an areas like if there is lack of services at primary care psychology level, or if there are lack of services, the only thing which parents feel their children needs to have medication so that at least they could something could be done for them. Yes, I do acknowledge there are examples, but the findings of this report do reflect that we are in line, at par with international prescribing practice, but I think I'll leave Dr. Burke to, as an expert, to give more idea.
Yeah, look, I very much agree with that. Compared to international norms, nationally, our prescribing rates are quite low, right? And in some areas, actually, there's an argument to say that we should be prescribing more, right? Notwithstanding that, Maskey made some very specific recommendations in one particular area of the country, but certainly what we've seen coming through in the national prescribing audit wouldn't reflect the same as that. But what you can see is prescription in isolation, right? So I would vary that, change the terminology from over-prescribing to prescription in isolation. So I would never prescribe for a child if they didn't need it, but if I didn't have a psychological therapy available as well, it might look as if that's all you were giving. And unfortunately, we do have waiting lists for psychological therapies because they're more resource intensive. So that's where we need to be focusing our energy now, is to getting more psychological and talking therapies available. And we've talked about recruitment challenges in terms of that, but we don't have to recruit everybody, right? And the HSE has looked at initiatives like Silver Cloud in terms of how we can provide online evidence-based therapies to young people, right, without having to go through what can be quite a long process in terms of recruiting people. And we will continue to look at that and to buy in packages of care for young people in terms of cognitive behavioural therapy or family therapy until we step up our own capacity.